Welcome to the VA Innovation Ecosystem Podcast, a new podcast from the Department of Veterans Affairs that will focus on all the great innovative work being driven by VA employees to improve veteran care. I'm Andrea Poe, one of the founders of the VA Innovators Network, which is one of the efforts at the Department of Veterans Affairs that is focused on identifying, testing, and evaluating innovative ways to efficiently and effectively meet veteran needs. This inaugural episode focuses on innovative practices aimed at preventing suicide. Preventing suicide among veterans and service members is a major challenge across VA and is VA Secretary David Shulkin's top clinical priority. First, some stats for you. A recent report found that risk for suicide was 22% higher among veterans when compared to U.S. non-veteran adults. And in 2016, 20 veterans on average committed suicide each day. 14 of those veterans were not under VA care, which presents a particular challenge for VA. How can we prevent suicide among veterans who we don't see? VA employees are working diligently to solve this problem, and some of the solutions VA is identifying can work in the private sector as well. On today's episode, we'll feature two practices created by VA employees that help prevent veteran suicide. At one facility, a suicide prevention coordinator is working with faith-based leaders and community members to identify and counsel veterans at risk for suicide. Elsewhere, VA employees are using predictive analytics to identify veterans with suicidal ideations. Finally, at the end of this episode, we'll discuss the role of social media in suicide prevention with Facebook's Global Head of Safety. But before we dive in, if you or a loved one are a veteran or service member and feel you need help, please dial the Veterans Crisis Line at 1-800-273-8255 and press 1 to talk with someone. Our first practice started at the Stratton VA Medical Center in Albany, New York. Preventing veteran suicide by partnering with faith-based organizations engages faith-based leaders and community members to identify, interact with, and refer veterans and service members who may be at risk for suicide to VA care. Joseph Hunter is a licensed social worker and the suicide prevention coordinator at the Stratton VA Medical Center, and he's the driving force behind this practice. I'll turn over the podcast to Dr. Ryan Vega, Director of the Diffusion of Excellence Initiative, who will talk with Joe about this practice.
So, Joe, why don't you introduce yourself? Tell us your name, the VA Medical Center that you're currently working at, and your title at that medical center.
My name is Joe Hunter. I'm a licensed clinical social worker and suicide prevention coordinator for the VA, and I'm currently at Stratton VA Medical Center in Albany, New York.
So what was the elevator pitch that you gave for your practice in the last Shark Tank that you were, one, successful in being selected as a gold status practice?
We have approximately 120 suicides daily in this country, and 20 of those are veterans. The VA has been very successful and aggressive in terms of treating those veterans who are at risk, who are in VA care. But we know that only represents about a third of the veterans dying each day by suicide. So there are about 14 veterans dying by suicide on a daily basis, and we needed a strategy to try to reach out to that population. You know, most people don't realize that 2/3 of all gun-related deaths are suicides. We don't have to sit idly by. We can get involved, and we can involve communities. So the idea was, let's create a mechanism by which we can empower clergy and other champions within faith-based organizations to help us by sharing an educational video widely within their community that trains them on specifically how to recognize warning signs and leads them step by step on how to intervene with somebody, to have the conversation, to validate their feelings, encourage them, and ultimately link them to care, whether it's VA care or vet center or even support through the faith-based organization. We developed a sun, soil, water metaphor where the seed is an unmet need, an unmet spiritual or emotional need. And that just seemed to be a really nice fit for, going into faith-based organizations. Knowing that we needed to do something a little bit different, a little bit more instructive in order to make it work with the model of going into faith-based organizations.
you sort of identified an unmet need and felt that this practice specifically was sort of aiming to solve that problem by getting more of that spiritual connection and that sort of emotional, the cognitive and emotional challenges that surround suicide and even depression, and really trying to aim to solve that by going out in the faith-based community. Did you see any other areas by which this would really help potentially bring veterans into the VA, or maybe to sort of move further upstream in the care delivery process? What other barriers and problems did you encounter in your career as a suicide prevention coordinator, and why so many veterans that are at risk aren't really getting services in the VA?
We have 14 veterans who aren't getting to us because they are, out there doing their thing. They don't know about VA services. In one of the implementation sites is Salt Lake City. We have Billy Prittis who's leading the project there. He's a chaplain. And he shared with us on Tuesday that just by going out and meeting with these faith-based organizations before he's even held his first clergy event in a high-risk community, he has already, by way of those conversations, drawn in 40 new veterans into care who were at some level of risk for suicide. He just talked about one person who was very high risk. Veterans, like everybody, can deal with very difficult things. Sometimes veterans have some unique things that they're dealing with, and there are places that can help you. You can go to your faith-based organization. You can go to the VA. You can go to a vet center. There are local county mental health services. There are peer support networks. There are self-help programs. So part of this is we're teaching it through this video. These resources exist. They're everywhere, and that veterans can access them.
You've already alluded to sort of the increased access and the impact this has had just at one site at Salt Lake City, where we have 40 veterans now who have been referred for service, one who you identified as very high risk. So what is some of the feedback you're getting, not only from the clergy and the individuals who are partaking in this, but from veterans themselves about this practice?
The feedback that we have received from all populations, including veterans, is that they love it, that they get it.
What other objective, measurable criteria are you using to sort of look and say this is having an impact, both whether you can put some quantitative analysis on it? Sounds like that would be challenging for a practice that's so new, but particularly qualitatively, what are some of the things you're looking at and some of the things you're hoping to measure, both from a value impact and also to demonstrate that this is going to be effective as it continues to spread?
We have all kinds of measures in mind. I think one of the most powerful indicators that this is working is going to be hits on the website, on the public-facing website, once we have that up and running. We can track that. We can see how many people get certificates. That's good, hard data. In addition to that, how many clergy did we reach? How many people did the clergy touch within their own faith-based organization who actually were trained? We're tracking all of that. That's kind of like implementation data. Is it actually being implemented the way we planned? In terms of outcome data, though, we can get some of that by looking at the number of referrals coming from, like crisis line referrals, for example, coming from a particular community that we went into. And we can look at changes in VA enrollment coming from communities. What's nice about this is that even though we're targeting veterans through the faith-based organizations, obviously we're also teaching people to recognize anyone, not just veterans, who are at risk. So by partnering with other organizations, they're going to help us do what we're doing now even more robustly. This is not only veterans, but help everybody.
I want to know your experience both in the VA and sort of how that evolved. I know you've been with the VA for some time, but how sort of that evolved and parallel sort of the passion that you bring to a practice like this and the passion that you have for suicide prevention.
I came to the VA 10 years ago. I wanted to be part of the suicide prevention mission. I think back about when I was younger. I really never considered a military career, but after 9/11 and recognizing, how many men and women were putting their life at risk to get involved in protecting our country, I really grew to have a much deeper appreciation for the value of and importance of our service members and veterans. And so I had been working in New York State at the time. I had a nice job there. I was working in evaluation in alcohol and substance abuse treatment. But I saw the opportunity to come to the VA in suicide prevention. I really felt like it was something that was going to be meaningful and challenging, and so I definitely wanted to become part of that.
There's so many layers of complexity to suicide prevention, to suicidality. You sort of kind of hit on a wide array of approaches. And I think that's what we sort of understand we need, that there's not going to be one direction we have to go. We sort of have to come about it at all angles and to have innovative solutions like your practice to add to sort of the repertoire and the arsenal we have, so to speak, to really tackle this project. I want to thank you for taking your time to talk about your practice.
Thank you. I appreciate that. And, it's my pleasure, but it's also my honor to be able to do this.
Our second practice came out of the Atlanta VA healthcare system. The Recovery, Engagement, and Coordination for Health Veterans Enhanced Treatment, or REACH-VET, uses a predictive model to analyze existing data from veterans' health records to identify those at an elevated risk for suicide, hospitalization, illness, or another adverse outcome. This allows VA to provide preemptive care and support for at-risk veterans. I'll turn over the podcast to Allison Amarin, an innovation coordinator with the VHA Innovation Program, who will speak with Dr. Jody Foster and Aaron Egan, two key players behind REACH-VET. Dr. Foster is the director of VHA's Program Evaluation and Resource Center, which is part of the Office of Mental Health and Suicide Prevention. Aaron is the National Program Manager for REACH-VET.
Hello, Aaron. Hello again, Jody. Thank you for joining us. And if you could just please introduce yourself, tell us a little bit about your role at VA, of course, your name, just a short background about each one of you.
Hi, I'm Jody Trapton. I direct the VA Program Evaluation and Resource Center, which is a group that does big data work and implementation science for the Office of Mental Health and Suicide Prevention.
Hi, my name is Aaron Egan. I work for the Office of Mental Health and Suicide Prevention, and I'm focused on suicide prevention efforts in the office. I primarily work on innovation and program development efforts, and I'm the National Program Manager for REACH-VET, our clinical predictive analytics program for suicide prevention.
Give us just a 1-minute summarization of REACH-VET, what it is and how it impacts veterans.
REACH-VET at its heart is a clinical program where we take innovative work in predictive analytics and modeling of risk for suicide and other adverse outcomes and use it to identify our very highest risk veterans so that their provider can review their care, look for opportunities to enhance that care and engage the veteran, and then reaches out to the veteran to talk to them about what their needs are so that we can make sure those needs are being met.
What are things that you see that are troubling veterans and more likely putting them at risk?
So the predicts we use in our current model are things that we can easily mine out of the medical record. So they include things like basic demographics, so age, gender, marital status, where in the country people live. We look at their past history of events, so if they've had any suicide attempts in a recent time period. And then we look at a variety of diagnoses. So we look across their clinical diagnoses and what they've been getting treated for. We look at their utilization, things like have they shown up in an emergency department, have they been in an inpatient unit for psychiatric.
So if someone is flagged as being a risk for suicide by this algorithm in the system, what happens? What happens that's different? What's the usual process, of screening? And with this model, how is it different?
So REACH-VET is really unique because it combines our robust electronic medical record, which is a great resource within VA, with predictive analytics to create a clinical program that impacts our veterans who are, statistically at least, at highest risk. We update the model monthly. The facilities then have a display of the veterans who are in the group, and the coordinator at the facility reaches out to a provider for a veteran who's identified, and that provider then reviews the care and looks for opportunities to enhance or engage that veteran to make sure that we're really not missing opportunities and taking full advantage of our ability to identify the statistical risk, while at the same time recognizing that just because somebody shows up in ReachVet doesn't mean that they are clinically currently at risk or even having thoughts of suicide. It just means they share a lot of similarities and have some pretty complex factors in their healthcare. And we want to make sure that we are meeting their needs as fully as possible.
What's the impact so far? What have you seen numbers-wise, or any stories or anecdotes that you've heard from the field about how it's directly impacting?
The feedback from veterans has really been very good. There's been some really interesting and encouraging kind of stories from veterans that have come back from the facilities. One of my more recent and personal favorites was a veteran who was identified several months ago, and the facility couldn't get the veteran well engaged in care. They hadn't been engaged. This was part of the challenge with this person. But the coordinator at that facility really took it upon herself to go out of her way to try and reach out to the veteran. It's actually over Thanksgiving weekend when this veteran ended up in crisis and called and left several messages for the coordinator on Sunday afternoon, and actually said in the message that he remembered her name and her number, and that obviously she cared about him because she reached out and left him a message and told him how to get a hold of her. And he came into the emergency room that Sunday night and was able to receive help. He ended up being admitted to the facility. But it was a really great reminder that when we use data in this way and we're doing these big national programs, we're always focused on what's the impact and what are the metrics. And those are certainly important.
Going back to the genesis, where did it start? Where did the idea come from? How did it transform into the first iteration and now? And then we can talk about how it was implemented. But where did it start?
So John McCarthy and his team out of SMITREC, which is another part of Office of Mental Health and Suicide Prevention, developed this original predictive model and just found that statistically they could build what looked like a statistically valid model that out of medical record predictors that could do a pretty accurate job of identifying people at high risk. So ideas based on the clinical literature about what would be an appropriate follow-up for these high-risk patients. What could we do clinically to potentially help them? And I believe at that point, the Innovations Office got involved and helped to move that idea forward, both in terms of trying to do some additional optimization on the models, as well as trying to build a demonstration system that would allow those models to be turned into clinical decision support to help get those into the clinic. So we stepped in, helped take some of the tools that were built out of the Innovations Office, move them over onto platforms that could be rapidly nationally implemented across the system, and worked very closely with Aaron and his team to come up with systems for actually training the clinicians in the clinical interventions and in use of these dashboard systems.
If you had to pick one major disruption in the implementation, though at 3 months, I'm not sure you could have had anything that major, but the biggest barrier, the biggest obstruction you had to get through, what would it be?
It would be a toss-up for me between the technology challenges that we faced and Jody and her team were able to overcome for us, and the effort required to essentially educate thousands of people across our system about what the program was and what the expectations were.
What's next?
Almost every week, we make some tweaks about either guidance or a technical solution to make the program easier and more efficient. So that's one of what will be next, is we'll continue that work. Obviously, effectiveness of the program and this initial report will be key, but really that's work that's going to continue through this next year until we have a more robust group of veterans to evaluate here. So we'll continue to look at that. And then expanding, not necessarily ReachVet, but how we use predictive analytics. This has been a great kind of model for how we can use predictive analytics to really impact care, but it has to be useful and convenient and impactful for clinicians. And Jody and I have worked a lot together to find ways to do that.
Thank Diffusion for having us all, and look forward to speaking again soon and hearing about the future of ReachVet and the other endeavors that you all are working on. Thank you.
Thank you, guys. Happy to do it.
Our last segment focuses on how Facebook is using artificial intelligence and social media to proactively identify individuals at risk for suicide. Listen on for Ryan Vega's interview with Facebook's Global Head of Safety, Antigone Davis, to learn more about how Facebook is using technology to help combat suicide.
Well, Antigone, it's a real pleasure to meet you today. If you wouldn't mind, would you introduce yourself formally and sort of tell us your role at Facebook?
So my name's Antigone. I'm Antigone Davis, and I am the Global Head of Safety at Facebook. And what that means, because it's quite a mouthful, what that means is that my team are working across the different teams at Facebook to really identify opportunities to lead on issues of safety. So, for example, with the particular projects we're going to be talking about today, my team has worked with mental health experts to really gather their expertise and make sure that that's reflected in the tools and the products that we're building and providing to the Facebook community.
There's a lot of public excitement and awareness around this idea of Facebook using AI to scan user posts and identify those at risk for suicide. But if you wouldn't mind just telling us a little bit more about the project in depth and how the team came up with the idea and then sort of actually started putting the building blocks together to get to where you all are today.
You know, we've been working on the issue of suicide prevention for well over 10 years now. And actually, it began with something that had been occurring in the community where we are located, a cluster of suicides, and an effort by engineers at that time to really see if there was a way that we could help. As a result of those efforts, one of the things that we learned pretty early on from suicide prevention experts is that, you know, one of the best ways to actually prevent someone from moving from a suicidal ideation to action is for someone that they are connected with, perhaps a family or a friend, to reach out to them. And, you know, if you think about Facebook, our platform is about connecting. And we are very committed to building a safe community. And there is a real opportunity to utilize the connections that are happening on the platform to really help on this particular issue. Early on, we developed a tool that allows people to report content that may look like someone is thinking of harming themselves. So, you know, obviously friends and family are really in the best position to identify that content. They can report it to us. And when they do, we will provide them with resources to reach out to that individual. So, for instance, if they want to reach out to that individual directly, we give them the opportunity to do that. They may not always know how to reach out. So we provide them with resources or the ability to contact a helpline to understand better how to reach out, as well as some tips developed with experts inside of the report so that they can reach out. When we get that report, we have people who are trained experts to review it. If it looks like it makes sense to send resources to the individual, we will send resources quite similar to the resources that the individual who reports has. So the opportunity to reach out to a friend, to reach out to a helpline, as well as some tips that have been developed with experts. If our viewers think that perhaps we really need to reach out to someone immediately, that the person may be in immediate harm, we will work with first responders to get that individual help right away. More recently, we launched, and I think this is what you're referring to, the use of AI in this process. So utilizing pattern recognition, we can actually identify posts that may contain content that indicates someone may be thinking of harming themselves and actually get that report prioritized so that we can actually potentially get them to a first responder faster.
It's really fascinating work, and certainly I think there's a lot of excitement about the impact it's potentially going to have. So when individuals or Facebook members are identified as potentially being at risk, what happens? What's the connection piece for identifying them and then getting them either to the authorities or to the services that they may need?
Certainly. Well, in the case of a report, the connection is actually someone who has seen that content, a family or friend or somebody else that they're connected with, and reports it to us. But actually, those same individuals have been very helpful in the use of AI. So utilizing pattern recognition, for example, responses to a post or a video that say something like, "Are you okay? Do you need help?" Those are very good signals in identifying content that may indicate someone is thinking about harming themselves. So the connection is actually really built off of the connections that we see on our platform. It is quite amazing to see how people will respond with offers of help or, offers of comfort or support when someone indicates that they may be in distress. One of the really amazing things when we made this announcement, at an event when we made this announcement, was there was an individual a veteran, in fact, who has started a group on Facebook for veterans who initially the group was actually just started for veterans as a way to connect on our platform. Over time, based on a particular incident that happened inside of the group has begun to offer support and comfort and help to individuals who may be in distress or be thinking about harming themselves. And they've really developed a whole support network. These kinds of connections are the kinds of connections that have really informed our work in this area.
It's really interesting that you comment about the sort of the social network aspect and the connection aspect. There's a practice ongoing in the VA in trying to partner with faith-based organizations and community outreach to sort of think about how you tap into that network to reach veterans who have these thoughts of suicide ideation that we're sort of missing. So I think it's really fascinating how you all have taken this amazingly comprehensive approach and then sort of layering it onto a social network and then now using AI and machine learning to sort of take it to the next level. Can you speak briefly about some of the challenges that your team encountered in getting a project like this off the ground?
I wouldn't actually think of them so much as challenges in a way, as more actually the pieces that we need to think about to do this in a thoughtful and careful way. So obviously, we have been working with experts in the area to really help identify how do we talk about this in a way that is meaningful and will resonate for the people, both for the people who are interested in providing support to somebody, but also for the people who may be experiencing thoughts of suicide. And how do we incorporate that information into the development of our tools? And we spoke not only with mental health experts, but also with people with lived experience to really understand the experience and ensure that we're building in all of their feedback into what we develop.
Just hearing sort of a little bit more in-depth aspects of your approach to this initiative, it makes it even more impressive, the work that you all are doing. So kudos to you all. And I think from a provider standpoint, this is exciting because it's sort of crossing a chasm and a challenge that we've struggled with for a long time.
It's the nice of you to offer kudos to Facebook. I'd like to do two things. One is to really offer kudos to the community of people who are on Facebook, because it's their action and their interactions that really have informed this work, as well as the work of mental health experts that we've been working with. So, we know that speed is critical here. And when we have opportunities to utilize the signals from the community, from our mental health experts, from the 80 partners that we have around the world on this, to really create a tool that's responsive and builds off of these connections, that's exciting for us because, ultimately our goal is to help build safe communities on and off of Facebook. And then I want to just offer kudos to you because it sounds quite a bit like the work that you're doing is really designed to do a lot of the same thing, which is to look for best practices and ways that people are connecting in this area to ensure that people are getting the kind of support they need. So thank you.
Thanks for listening to the first episode of the VA Innovation Ecosystem podcast. We hope you learned something about VA and the work employees are doing to improve care for veterans, and we hope you'll join us again for the next episode, which will focus on the use of 3D printing to enhance the veteran experience. Until next time, I'm Andrea Polito, and this is the VA Innovation Ecosystem podcast.